I'm Dr. Harold Burstein from Dana-Farber Cancer Institute and Harvard Medical School. Thank you for joining us today for a discussion of the management of hormone receptor positive breast cancer. Today we're going to be talking about an interactive patient case with a particular focus on CDK4/6 inhibitors and their role in the management of advanced breast cancer. This is a whole new targeted class of drugs. We've seen a lot of data coming forward in the past year or two, and it's a great opportunity to take stock of where best to use these drugs. To help that dialogue, I'm delighted to be joined by Dr. Joyce O'Shaughnessy. Joyce is the Director of Breast Cancer Research at the U.S. Oncology Clinical Trials Network and a medical oncologist at the Baylor Sammons program in Dallas. Joyce, it's great to see you.
Good to see you, Hal.
So before we get into metastatic disease, I want to ask you about a topic in adjuvant therapy, just to pick your brain a little bit. As we are using longer durations of treatment, many of us are encountering challenges with patient adherence to treatment, issues about compliance and taking the medicines reliably. What are some of the tricks you have, because I know you run a very busy clinic, what are some of the tricks you have to both inquire about patient adherence to treatment and help them assure that adherence?
Well, it's a huge issue, and I actually have posted in each of my exam rooms some abstracts from articles that show decreased outcome, poor outcome.
You put them in the rooms for the patients to see.
They're right there along with the
exercise. I love that. I've never heard of that before.
Exercise, yes, the exercise. Yes, yeah, I have that there because people read because they unfortunately wait a little bit of time.
Not that you're never not on time.
I haven't. So it said, because unfortunately, if you like the Kaiser series, if you don't take your medicines, you have a lesser outcome, from disease-free survival. So unfortunately, there was a connection there. So I find the issue of adherence to be the biggest problem in the beginning, in the first year to two. Once we get over that hump, women generally will go the 5 years, and those who make it the 5 years and are doing pretty well, I think generally speaking, if they're higher risk, they're like, if it ain't broke, don't fix it, basically,
Right. They know what they're getting.
We'll go 10 years for the node positive. So the issue is the first couple years. Now, I will say this, if women continue to come back, our big issue, I think, Hal, is that we don't have reliable ways to get the gals who don't come back for whatever reason, whether it's loss of insurance, whether it's difficulty with transportation, or whether it's a bad side effect, or what have you, because they'll be lost to follow-up and they'll get one or two letters from the office, but then if they don't come back in again, they're lost to follow-up. And as we get better with our EMRs and our ACOs and all these things, where we're going to be responsible for numbers of lives, it's going to be increasingly important to reach out to those women and get them back in, because I think if we persist in trying to get them back in, at least some of them will come back. But for those who do come back, I think, and I've seen data on this, that what matters is that doctors are listening to the complaints and are actively trying to problem solve with the woman.
Okay.
I think that's what really matters. Now, so it means an interruption of therapy, letting the side effects diminish, switching to a different therapy. Of course, this is after you try making sure the vitamin D levels are good, getting some stretching. It's mostly AI related,
Right.
Although sometimes it's tamoxifen, sometimes it's an SSRI to help with hot flashes, etc. Making sure sleep is good, But it's that problem solving and stopping one, letting the side effects go away, then going on to the next one, etc. But I would say that of the women who are really struggling with the side effects, there's a small percentage, 10, 20%, who at the end of the day, we both have to conclude they can't take the drugs.
Right.
It's not zero. And then I'll tell you, as I've gotten into this business more and more, I think that not always, but for the more luminal A, not the aggressive kind, but I think lifestyle, being on the leaner end of your normal body weight, and not gaining weight and exercising and keeping alcohol at a very low level, I've become increasingly convinced that the so-called healthy lifestyle in many ways can make up for the inability to take endocrine therapy.
Interesting. That's certainly a hypothesis being tested by a couple of trials right now, so it'll be interesting to see if maintaining a healthy lifestyle really does translate into those benefits. I like a couple of tips I really heard there, which were, first, I love this idea of putting the actual data in the room for people to see, like, hey, it's not just me telling you this makes a difference. And then secondly, of course, listening and trying to intervene. That probably goes a long way towards at least getting people
Building
to think about it.
relationship. They know you're in the game with
care.
them there. Yeah. Yeah.
Good. All right, well, let's switch gears now and talk about management of advanced disease, which is really our theme for the day. And the case we brought with was a 53-year-old woman who'd been diagnosed with advanced breast cancer a little while ago. She presented with a mammographically abnormal finding in one of the breasts. She'd had breast surgery. At the time of her breast surgery and sentinel node evaluation, she was found to have multiple positive nodes in the axilla. A subsequent staging workup was done. She found to have isolated bone lesions. Fine needle aspiration confirmed metastatic disease to the bone. So she's de novo metastatic disease. She began bisphosphonate therapy and she began an AI. She was on letrozole for the better part of around a year and a half or 2 years, but now she's got progressive disease in the bones and she's got some new mediastinal lymph nodes. So progression despite prior AI therapy. Minimally symptomatic, really a little bit of bone discomfort and not much else going on. So the question that we're thinking about more and more here is, what would you offer to this patient with minimal symptomatology who's progressed on an AI? And before I even ask you the clinical management question, let me ask you, do you want to know what's going on to the estrogen receptor in those mediastinal lymph nodes?
Probably not, Hal. I think of different metastatic sites as more or less endocrine therapy sensitive. So bone, endocrine therapy sensitive, parenchymal lung or pleura, and lymph node disease in general, more likely to be ER sensitive. Her natural history too is encouraging. You know,
Right.
she went over a year and a half on Firstline AI. That's very encouraging. The likelihood is she'll benefit again from another line of endocrine therapy. So no, I wouldn't go after even if she had an easier to biopsy. You know, if she had a skin nodule or a very superficial, I might consider it from the point of view of a HER2 mutation. Could have one of those have popped up or something?
Idea.
Of course, these days we can get ctDNA, which is pretty reliable.
Are you routinely doing that?
You know, because of data that I think there's a decent correlation between the results of next-gen sequencing on a contemporaneous tissue and blood sample. It's a pretty good concordance. The one thing I will look for over the course of disease is a HER2 mutation or a new amplicon. I am finding them more than the 2% that you find on the primary breast cancers.
Interesting. So you think these are, just to be clear, these are point mutations in HER2 more than amplifications.
But sometimes new amplification too,
Really?
particularly the lobular breast cancers, and just a little, clinical observation that needs to be borne out. But peritoneal disease. For some reason, the lobulars in the peritoneum will pick up HER2 amplification. And interesting, almost a situation where if you've got the ESR1 mutation, the cancer does the estrogen receptor mutation,
Right.
You won't have a HER2 mutation. So if somebody has an ESR1 mutation, much less likely they'll pop up, although late line, a separate clone that didn't have an ESR1 could pick up a HER2. But it's almost like the cell, it's mutually exclusive, that the cell doesn't need both. The cell can get by on either ESR1 or HER2.
So I knew that the lobulars were more likely to have these relatively rare HER2 point mutations, but I hadn't specifically heard that peritoneal disease was associated with that.
Yeah, no, that's just strictly a clinical observation.
That's a Joyceism?
That's a Joyceism,
Okay,
yes,
just want to be clear.
yes,
This is the
yes.
Joyce.
I like to get those out there.
The New England Joyce Medicine of Journal of Medicine. Okay. So you're not keen necessarily to biopsy her right away. You say, okay, you got progressive disease. So what are you going to talk about with this patient in terms of her options next?
I'm going to be very happy to tell her that there's very good endocrine therapy for her, that we are, miles away from considering any chemotherapy for her. She's still, thankfully, because some people will progress to bone. If there's some clone that grows out that isn't so dependent on the estrogen receptor anymore, it'll go to liver, and hers didn't. It stayed in what I consider to be, highly endocrine therapy sensitive sites of disease. So I would be pretty clear. I wouldn't have a whole long list on this one. Hal, I would definitely recommend fulvestrant and a CDK4/6 inhibitor to her, because though she's pretty darned endocrine therapy sensitive, if she goes on to fulvestrant alone, it's only a 3 to 4 month median PFS. Now, median, of course, means half will go longer.
That is the definition.
And so she could get longer than that, and she'd be the one that would do it. So, but the data looks so good. You know, the data looks so good, she might as well double or more her PFS. You know, so and the two that we have only one that's commercially available that's approved by the FDA, and that's palbociclib.
For Secondline, right?
For Secondline, and we anticipate abemaciclib will be approved soon, based on the Monarch 2 trial, which was a very similar trial to the palbociclib Paloma 3 trial. And then we await, there's a third one, the ribociclib. We're awaiting the results of the Mona Lisa 3 in that same second-line population.
Yes.
So we will have 3, I'm sure, to choose from, but right now we just have 1. But soon we'll have 2, I think later this year probably.
So fulvestrant with the CDK4/6 inhibitor, do you see any big clinical differences between these aside from the actual schedule of the drug administration for the CDK4/6 inhibitors?
So I think that the palbociclib and the ribociclib, and I've really looked carefully at the data. I have a slide that lists the patient populations and you know, response rates and PFS and hazard. You know, they look very, very similar to me. Very, very similar. Identical. Identical. The abemaciclib is maybe well, it's a little bit different. I think it's fair to say it's got a little broader spectrum of activity. It's not so focused on just CDK4/6. It gets a couple of the other CDKs in there. You know, it's got a broader kinome profile that it goes after, and then later line, it appears to be, not that we have a ton of data, you know, from palbo and ribo, but later line, the Monarch 1 trial did look encouraging, and I've had the opportunity to use the abemaciclib late line
in resistant cases and even after chemotherapy.
Oh yes, after multiple with luminal B biology, you know, lots of amplicons in there and such, and I've had some dramatic durable responses. So I have also heard that with palbociclib.
Right. I mean, it's always unclear whether these are just class effects and patient selection.
Right. Exactly. Because I've certainly heard that, and actually have seen it myself, even with a late line, very heavy liver metastases who just hadn't happened to have. You know what I mean? When it first came out, so we saw some of that too with the with palbociclib.
So. Fulvestrant with the CDK4/6 inhibitor. Let me ask you, where does everolimus fit these days?
So I do use everolimus as a next line.
Okay, so third line endocrine therapy.
As long as they don't have liver disease. Now here's another Joyceism.
This is a Joyceism.
It's a Joyceism coming your way. So I have seen in my own practice so far a number of occasions where at a minimum the everolimus just didn't work, and at a maximum where I had the impression that the liver disease may have been a little bit more aggressive. Now, whether that was stopping the CDK4/6 and you're getting a little rebound, or whether there's something about inhibiting TORC1 at that moment, having queried my colleagues about this, Sarah Hurvitz at UCLA has a case of a patient who did well on a CDK4/6 inhibitor, lots of moderate liver disease, got everolimus, did just great on it. So I wonder whether it's going to be interesting to see if we can tease that out at the end of the day.
So to be clear, the Joyceism is that everolimus does work in hepatic disease or does not?
Does not work. So I usually will go to capecitabine there.
Got it.
But every place else, I will
short
go
of the
on to
hepatic
short of liver
metastases.
disease, I will go on to everolimus with exemestane.
Let me ask you a hypothetical. If this patient we were discussing who got AI up front and then progressed and will get second-line fulvestrant and CDK4/6 inhibitor, if she'd had letrozole plus a CDK4/6 inhibitor and had 24 months of tumor control, would you continue the CDK4/6 inhibitor and switch endocrine treatments?
No, I wouldn't, because first of all, we have no clinical data at all. Secondly, the preclinical data are not really encouraging to me in that regard. At first I heard there was complete cross-resistance between them. Now I'm hearing, well, maybe that's not entirely true, that there may be some rationale for some clinical trials looking at bringing in a different one when you've progressed on one. So some of those trials are ongoing. I know of one trial ongoing. But as I look at the mechanisms of resistance, at least preclinically, to CDK4/6 inhibitors, I'm not convinced that there's even a hypothetical reason to keep going at this moment. So no, I definitely don't.
Yeah. I'm interested in the question, and we are supporting one of those clinical trials you mentioned where there's a randomization to ongoing CDK4/6 inhibition or not. It'll be interesting because in certain paradigms in breast cancer, like anti-HER2 therapy, we've established that multiple lines of treatment can be clinically valuable. And whether it really plays out here or not, I think remains to be seen.
Mm-hmm.
So I'm kind of excited about those studies. Let me ask you a quick word about toxicity for CDK4/6 inhibitors. Do you see major differences in the earlier versus later use of these drugs? My own clinical impression has been that in those patients who've had a lot of prior chemotherapy, either in the adjuvant setting or even in the metastatic setting, that you see more in the way of myelosuppression and other toxicities when you use these drugs. I don't know if that's, does that rise to the level of a Joyceism, or is that not quite there yet?
Yes, I'm tracking with you on that one. I'm thinking of the women who are on later line just because they have had multiple lines. It wasn't available to them earlier, and they do have more in the way of myelosuppression. Yes, I would definitely say that prior chemotherapy probably does predispose to a bit more in the way of, but I'm tolerating, rightly or wrongly, I'm tolerating grade 3 neutropenia chronically without dose reduction, because it says in the beginning, all the package inserts, they say, give it a little time on the grade 3, but if it persists, dose reduce. I haven't been so much. I've been tolerating it.
So if someone comes in with a neutrophil count of 850, you're
staying
let
the
it
course.
roll.
Yeah, because it depends. I'm not asking them to come in, week by week to see if it doesn't recover.
Yep.
You know what I mean? It's a little hard because they come in when they come in.
Right.
You know what I mean? And so they'll be at the end of the cycle. They'll be right at the start of the week off, and I'm like, well, I don't know if you're going to recover. It's hard for me to know exactly what's going to go on, but as long as they're doing fine and. Knock on the wood, I don't have any sense that there's any kind of infection risk that I've seen so far, even minor stuff. I haven't seen anything.
So I've been asking a bunch of people this question. I don't have a clean answer on my own mind, but do you think it's better to use these drugs in first line or in second line, all other things being equal? I mean, I know the numbers are better in the sense that you get a bigger shift in PFS in first line, but that's just because you start with a longer baseline and it's the same hazard ratio. Do you really think it matters that much whether you get it in first or second line?
I do favor the first line because I think the adage of giving our very, very best therapy up front when there's presumably fewer numbers of heterogeneous clones and there will be later line, you're stacking the deck in favor of longer disease control, as you know, is the name of the game. These wonderful years of good quality of life and few trips to the doctor's offices, those are golden years. We obviously want to maximize those. The problem with breast cancer, as you well know, is that it's unpredictable. You can save something really good for the second line, and then something else comes up. Suddenly there's a brain metastasis. Even in the ER positive, and you just don't get that. You don't get the guarantee. So partly it's that, but I've seen I know when Ingrid Mayer did a discussion, and she put out a little, and let's even concentrate on the more indolent so-called luminal A, bone only, where you think you could do sequential. You're pretty clear you're going to be able to do sequential, and you do the math on duration. And so it's just that we don't know, for example, if you start with fulvestrant, which Falcon would say if you're going to start with an endocrine agent, you'd start with Falcon for your bone onlys, you're going to be at 22 months median PFS, okay? But then we really don't have data with AI and CDK4/6 inhibitor immediately following fulvestrant. So there's a little bit of extrapolation going on there.
So I get two more quick questions. We're into the lightning round phase here because our hour is coming due. Are you giving first line fulvestrant instead of an AI based on those Falcon data?
No, the only time I would is if a woman had multiple comorbidities and a combination with the CDK4/6 inhibitor might be a little bit toxic, but otherwise I'm always going with an AI and CDK4/6 inhibitor first line.
And the final question I'll ask you is, do you think it matters if there's a survival benefit ultimately shown for these drugs?
I don't, Hal, because women live so long, thank God. Well, goodness gracious, we wish it was a whole lot longer, but relatively speaking, in our world where we're looking for these survival advantages, it's so many years down the road that I just think there's too much. Plus the fact, as you know, the studies are not powered. They have to be in the thousands to power for survivals that are going to be 2 and 3 and 4 years down the road. Statistically, we know that from some very nice modeling that's been done. So there, even a meta-analysis would still be underpowered, to look for those who know. I actually don't think so.
Interesting. Yeah, I mean, I don't think you have to. We've used these drugs and there clearly is clinical benefit. But at some point, if you're shifting that first-line progression by over a year, it'd be nice if you began to see a survival benefit. I think the benefit that probably is really true is it delays the time to chemotherapy initiation for a lot of patients.
Right. And those that's that golden period, and the longer we can prolong that, the better.
Great. Well, thank you very much, Joyce. I've been talking with Joyce O'Shaughnessy from the Baylor Sammons Cancer Institute in Dallas, Texas. She directs the breast cancer research program for the U.S. Oncology Clinical Trials Network, and we've been thinking about CDK4/6 inhibitors and other innovations in endocrine therapy for early and advanced breast cancer. I'm Hal Burstein from Dana-Farber Cancer Institute. Thank you very much for joining us.